experience as a professor of clinical pharmacology. He has presented in-service trainings throughout the United States and has trained for 20 years on issues related to contraception and women's health. He has more than 1,000 invited presentations and over 100 peer-reviewed publications in the field of pharmacology. So it is my honor and my privilege to introduce Dr. Glenn Farr. Give him a good round.
It's always been nice to be asked back somewhere. I've already talked to a few folks that have been here before, and I'm always surprised that you come back, but I do appreciate it. There's probably some new folks here, so it's good always to see you. We've been doing this around the Southeast, particularly Kentucky, for several years, and I always enjoy getting out and meeting other healthcare professionals, particularly nurses, because I teach all the nursing pharmacology for the University of Tennessee. In fact, I've got a former student back there, been about 3-4 years ago, I think she said, when she graduated. But there's been a lot that developed since then. But I do teach all of the nursing pharmacology at the University of Tennessee. Teach pharmacy students, medical students, residents. We did quite a bit in the area of drugs. And every year when I try to put these together, I think, well, there's not going to be enough for all day. And then you start putting these things together, and then you have to go through and throw things out and pick out just what you feel is important. And it's amazing if you don't really keep up with the field of healthcare and pharmacology. It's amazing the number of new drugs, new studies, and changes that occur. This past year, there hasn't been that many new blockbuster kind of drugs, but there's so many changes in the way we approach things: lipids, hypertension, diabetes. Those three areas right there, we could spend all day just talking about the recent developments and changes in the approach to those things. The other issue that I have in speaking to this type group is about half of you say, I don't want to know anything about lipids and blood pressure or anything. I work in women's care, I work in contraception, that's all I want to know, just tell me about Depo-Provera. Okay? Then you have the other half that says, I work in women's health, that's all I do all day, Depo and ortholemper and all these things. And he said, I want to know about all the other things that my patients are. So what I try to do is to give you a little of both, okay? So we're going to start with some general things. I'm going to share with you some really big stories in pharmacology and clinical pharmacy over the last couple of years or so. Then we'll get into women's health after lunch. We'll focus on that, and then we'll finish up with diabetes and arthritis and all the other things that the patients have. We will not have time to get into oncology drugs and a lot of other things, but I do have some miscellaneous things to share with you. With that said, I've tried to pick out what I feel is important, but what I would like for you to do is at any time, raise your hand, ask a question, what you want to talk about. Particularly at the end, I will leave some time to talk about anything you want to, or go back and look and see. I want this to be interactive. It can get rather boring sitting there all day long. That's one reason I have given you some what I call clickers. These are audience response systems. I've got some slides throughout that I'll ask your opinion. If you didn't get one, I've got plenty. Be sure to get one. You don't have to turn it on or anything. And by the way, it will not change your TV or open your garage, so don't steal them. I just ordered these, are brand new, and they're about $30 a piece because somebody keeps taking them from all the seminars. But anyway, if you answer A or 1, there 4 choices on most of these, just push that button. It will record it, and you'll see the total response. If you change your mind, it will take the last entry, but it won't take 4 or 5 entries. Do you need one? Yeah. Anybody else? That need one? Okay, here. Almost hit the bottom. Pass that back there. Anybody else? I've got a whole bag full here. Okay. All right, well, I think you have a copy of the slides. I've added a couple of things. There was a new drug approved for diabetes last week, so I've added that. And since I sent this to you, I will note that as we go. And my style of doing this is to give you about 400 slides. Some of them we'll spend a little bit of time on, some of them we'll spend hardly any time. There are references on each slide for where this material was gleaned, and you can go back if you have an interest and look further at it. So let's begin. The CE portion requires that you disclose any commercial interests, etc. I do serve on the Speaker Bureau for 70 past tour, trying to get folks to get vaccinated with not only flu vaccine, but HPV and things that you're mentioning here. So I don't think that's a commercial relationship, it is a public health issue. None of the objectives that we're going to be talking about today, you can read those as well as I can. I kind of described these previously. We're going to focus on women's care. Well, wait a minute, it's not opening up here. Hold on 1 second. Let me see if we can get this to open. So, it was working yesterday, just fine. Let me see. I'm going to do this tomorrow. It doesn't work, but it won't work. It wasn't working yesterday. I'll tell you what, I'll fool with this right much. I don't want to take all your time here at my time. And these first couple of inputs are not those that important. Okay, what I was going to ask is what your primary area of profession. I assume most of you are advanced practice nurses or nurses. Are there any other type of practitioner in here? So this is kind of giving you where we're going to focus. Okay. That's the way it's supposed to come up. Somebody's going to. Let me point out a couple of things here. This is a Gallup poll that's been done every year. For many years, nurses were not included. And about 10 years ago, they started including nursing in the choice, and since then, nurses have been number one. Before that, pharmacists were number one. But we went to number two, physicians, etc. It's interesting, some of you may have heard, and I'll be talking later, my wife is a second grade school teacher. So in our house, we're right at the top. We've got grade school teachers and pharmacists on there. Our lobbyist for the Tennessee Pharmacists Association is also a pharmacist, so I asked her where she identifies herself, whether a lobbyist or a pharmacist. So she gets fitted. But I just think that's interesting, and it shows respect. I think sometimes we as nurses, pharmacists, physicians, etc., don't realize how respected we are in society. Now, there's always a few bad apples, but on the whole, we are very respected. As far as drugs go, the number of drugs approved last year declined just a little bit, but it was still much more back in the 90s. 1998 or 96, there were 62 new drugs. Last year, there were about 27. In 2012, there were 39. So this kind of goes cyclical. We've been down in the teens before. But even at 39 or 27, That's still, think about this, it's a drug every 2 weeks. Back in 1996, it was a drug a week, more than that. Now I realize that not all of these affect your particular practice, but many of them do because patients are on more than birth control when they come to see you. So it does impact a great deal. There were 3 drugs that the FDA approved as what they're calling breakthrough drugs now. These are like major therapeutic advances for major diseases, or very effective, or will be used a lot. Hepatitis C is getting a lot of publicity right now. There's a drug called Sovaldi, which in the course of treatment, 3 treatments, is $84,000. You may have read about this in the fact that it is controversial, that Congress has gotten involved in the pricing policies and those kind of things. One thing that has made the news is that the company is selling this in Africa and other countries for like $5. And so it comes out that the United States is subsidizing care for the rest of the world. Now this is not I don't know enough to get political or anything, but that's not unusual that the United States is one of the leaders of this. We also do not have cost control in our country. Canadians do, etc. A lot of the government set the prices. That's for somebody else to argue the good or the bad, but there are a lot of very expensive drugs. Last year I showed you some slides of the top 6 most expensive drugs, beginning at $450,000 a year. It won't be long until we'll have $1 million drug around. So this is expensive. A couple of drugs for cancer, for CLL, etc., are considered breakthrough kind of drugs. Of those 27 drugs that were introduced last year, about half of them are what we call orphan drugs for very rare diseases, and about a third of those were for oncology cases, for cancer. There are only a couple or 3 that I consider to be widespread use, what you're going to get in the outpatient setting kind of thing. So those are the 3 breakthrough drugs for 2013. We use a lot of medication in our society. The latest data is 70% of Americans are on at least one drug, 7 out of 10. Now, if you consider the fact that most children are not on anything other than Ritalin, but we'll come back to that later, that means most adults are on 2 or 3 to make up for that. I consult with a nursing home in Knoxville. It's not unusual to have patients on 15 or 20 different medications. My mom is 92 years old, is on 13 different drugs. Well, actually 14, they just added back to them yesterday. She had some cellulitis and a little blister on the foot was infected. So she's on 14 different drugs today that she'll be taking, some of them up to 3 times a day. She tells me she gets tired of taking pills. That's not unusual. Where are most of those drugs given? Okay, you ready? The darker the state, the more drugs. In my calculations, we are right in the middle of the hotbed here. Tennessee's got a little bit along the river around Chattanooga, but the only part here is right up here in the corner of Indiana that's not all red. West Virginia is not far behind. But if you go out here, Wyoming, Colorado, they don't use any medicine apparently. But it's very, very rare. But this is the hotbed of medication right along the Appalachian Mountains for not only prescription meds, but also OxyContin, hydrocodone, a lot of drug abuse and things that occur along that way. Thought you might be interested in the top selling drugs for 2013. Abilify was number 1, $6.4 billion. Now, that is a lot of money, but if you compare that to Lipitor just a few years ago, before it went off patent, at its height, Lipitor sold $13.6 billion. Double that, more than that. Second is Nexium, Humira. You can read the list. Interestingly, this list changes significantly from year to year. Next year, Abilify won't be on there. Nexium will not be on there. Symbolical will not and aprn1. So 4 of the top 10 will not be there because they've gone generic. Nexium is not only generic, it's over the counter. But now it's a different drug, I'll talk about that. It's a different salt form of esomeprazole. But anyway, it's over the counter. Therapeutic classes. We spend more money, more prescriptions for antihypertensives than any other class of drugs. Second is pain. But look where contraceptives are. 12. 91 million prescriptions were written in 2012 for contraceptives. So you are not quite in the top 10, but you're close to that range. If you look at the money spent, this is 2013, we spend the most money on oncology drugs. Not that they're that common, but when you talk about some of these that are over $100,000, $200,000 for a treatment, it becomes very expensive. And there are those drugs out there. There's 2 new drugs now for not basal cell. There's one for basal cell, but one for two for malignant melanoma. We've never had a treatment for malignant melanoma. We do now, but it's over $100,000. So we spend a lot of money on medication. If we also spend a lot of money directly marketing drugs to consumers, DTC we call this. There's only 2 countries that allow that. The United States is one, and New Zealand is the other. I think maybe Australia and New Zealand are together, but anyway, New Zealand is what you read most of the time. Spent the most money on Cymbalta. I have mixed emotions about this. I know it sells products that let people know they've got some drugs, but most of the time they're not advertising life-saving drugs, unless you consider Viagra to be life-saving. The other thing is they start advertising, promoting these right before they go off patent. Cymbalta goes off patent, Celebrate's off patent, Abilify, aprn1. So you see a push right before they go generic to try to capture that last bit of the market. We spent $3.4 billion in 2012. A lot of folks say take that money and put it back into research and development. Others say take that money and lower the cost, but that's not happening. Medicine gets criticized for being so expensive simply because it is a visible part of the healthcare knowledge. We see the bills, we pay the co-pays, we see what the insurance company pays for that. We don't usually see the EOBs for the MRI or the CAT scan or something like that, radiology, laboratory, pathology. But medicines make up only about 11% of the total cost of healthcare. So in some ways they're a bargain. But in other ways they are expensive, but it's only about 11% in the total care. A lot of that is, as I said, because of cost control measures and good DUR programs, insurance companies, etc. Now, before we get started, particularly for those that haven't heard me speak before, I want to share with you the way that my wife and I handled the empty nest syndrome several years ago. As I mentioned, she's a second grade teacher, and we had 2 boys that have grown and left the house years ago. I'll tell them about them in a moment. So when the boys left the house, we replaced our 2 boys with 2 girls. Our girls were the canine variety, which leads me to this slide. It shows a woman pushing a dog in a stroller, and it says Noreen's having a tough time coping with empty nest syndrome. And you say, that's crazy, who would do that, my wife? she has to have somebody to take care of her. And if it's not the kids, it's the dog. So, when our boys left, we got 2 girls. Daisy on the left, our basset hound. But Polly, a little mixed breed we got at the pound. Shepherd retriever. Has anybody got basset hounds? I think I've asked this before. It's one person. Basset hounds are sweet dogs, but they are really dumb. They're really dumb dogs. Daisy passed away a few years ago. Polly just about a little over a year ago. We had to have her put to sleep. I'll talk more about that in a moment. Now, we also have two granddaughters. Miss Charlie is a golden retriever that lives with our oldest son in Knoxville. So we get to keep her quite a bit. Reggie is a little neurotic, psychotic schnauzer mix that our son in Charlottesville, Virginia rescued a couple of years ago. He seriously, he has real separation anxiety and all this stuff. One thing that has helped, this is not a commercial, but it's called the blanket on the name. Thunder shirt, yeah, thank you, thunder shirt. It's a real tight-fitting shirt that kind of calms it down a little bit. But he lives in Charlottesville. Our youngest son, bless his heart, I didn't know if he'd ever graduate from high school. He's got a degree from UT, BS in history. He's got 2 master's degrees. He's got a teaching certificate from the University of North Carolina. He taught high school history for a while, and then he was encouraged by his instructor at college of Charleston, where he got his 2nd master's to get a PhD in history. So he is completing that this year. He tells me he better at the University of Virginia. So I guess you'll be driving a truck for a living. What do we do with a PhD in history? Well, when he started 6 years ago, there were a lot of academic jobs, but right now those are not available. So we'll see what he does with politics, with Reggie. So anyway, as I was saying, about a little over a year ago, my wife called one afternoon. She got home and she said, "Paul, I can't get up." So I said, "Well, if you can get her in the car, I'll meet you at the bed and see what's happening." To make a long story short, somehow she had shattered her femur. She was 13, so we had to make a very difficult decision to have her put to sleep. This was a Thursday night by the time we got everything done. So Friday morning, I was actually, had to go down to Nashville for somehow that weekend. And I tried to be a good husband, and Friday morning she was sitting there and she had little tears rolling down her cheeks. And I said, "Well, we can get another dog." You don't say that on Friday morning after putting them to sleep. "I don't want another dog, rest off." That was Friday morning. I'm driving down I-40 about 5 o'clock. I get the cell phone rings. My wife's on the other line, and she says, she said, "I'm at the animal shelter." And I said, "Well, did you find the dog?" She said, "No, I found 2 of them. They're brothers, and they don't want to be separated. They're brothers and don't want to be separated." And so I was saying something like, "Well, if you think they'd be a good fit for us, you can." "Oh, I've already got them. I'm on the way home." I said, "Well, have you named them too?" She said, "Yeah, they're Sugar and Spice." I said, "Well, that's kind of a sissy name for boy and dog." I said, "How about Butch and Sundance?" See what their names are. I said, "They're Sugar and Spice." They are her dogs. I have never seen. She had to go out of town last week, and Sugar wouldn't eat for 2 days. He just hung his head. He would hunt for her through the house. You know, FaceTime is a wonderful thing, except it drove the dogs crazy. After about 2 days, I hooked up, so I showed her, I said, "Here's Mama." And so they just ran all across the house, hearing her voice, trying to find her. Then they hung their heads again, so it was probably not a good thing to do. So anyway, she got back, they recovered, and they're still there. They're little terrier bitches. Now, dogs are good, bad dogs are good, but the best answer is S syndrome. I've already shown you our grandkids. Each of our sons has blessed us with a daughter. So we have cousins here. Sophie on the left lives with the truck driver in Virginia. She is 11 years old in 6th grade. Veda just turned 5. She lives in Knoxville. She started kindergarten this year. And so that's a big deal. I didn't know in kindergarten when I went there, you just played. Boy, I mean, she was over, she said, "You want me to spell purple? Green?" I said, "Yeah." She just, I know she's not any smarter than anybody else, but men in kindergarten, they're really getting after it. Some of you may have some kindergartners. But anyway, I appreciate you looking at my dogs and grandkids. I'll be glad to look at you. This is still not working. But I would ask a question about generic drugs. I've mentioned this a couple of times. Most people say they're just as good as the branded, and we always have a few that say they're inferior, and one or two that say they shouldn't be used. But medical letter agrees with that most of the drugs, they have some concern about levothyroxine and epileptic drugs, etc., but most of the drugs they're very comfortable with, particularly oral contraceptives, etc. So there doesn't seem to be a problem. The next question I asked was, what are the percentage of generics currently? Sometimes the young folks answer 10%, middle age 25, the older folks get it right, about 84% on generic right now. If you look at the total market of prescription drugs, 84% are generic, but the 16% brand names make up 75% of the total dollars. That's where the big push is on generic drugs. This has gone up each year for the last, as long as I remember, particularly in '84, the Wax-Hatchman Act made it a lot easier to get generic drugs. You didn't have to go back and prove safety and efficacy, you just had to prove that they were equivalent. But when I was first in practice, probably less than 2% of drugs were generic. I do remember phenobarbital was generic, but it was made by Lilly. It was made by a major corporation. But that has changed significantly over the last several years. Here are some products that went generic in 2013. Interestingly, Niaspan and Trilipix were made by AbbVie, used to be Abbott Labs. That was their entire cardiovascular division. So they shut down. They closed the cardiovascular division. Because once a drug goes generic, they don't really promote it. Got a lidocaine patch, we've got another PPI, Acidex, Lunesta, I'm going to talk more about that in a little bit, Cymbalta, as I mentioned earlier, and then OxyContin, but it's not the abuse retardant formulation, the OPs versus the OCs. I don't know how familiar you are, but you can't get generic OxyContin in the crush-resistant form, and that's the only that's available in the United States. But the old form, is like in Canada, it is available generically, but not here. I mentioned two drugs that were going this year, Nexium and Celebrex. This is way too technical. It doesn't make any clinical difference, but just so that you are aware, the Nexium prescription brand is S-meprazole magnesium. The over-the-counter form is magnesium. His prescription is magnesium. The over-the-counter is strontium salt, S-meprazole strontium. So it's not technically a generic for Nexium. Again, that doesn't make any difference. The only problem is that this strontium is incorporated in the bone and it's not recommended in pregnancy in children. So that's a minor point, but it's something that might be important to know. The other thing is Celebrex. I put that one on there for this reason, to show you that things can change. Every drug has a date at which it goes generic, but it hardly ever goes generic on that date, because the lawyers for the manufacturers usually tie it up in court, where they cut a deal, they pay somebody not to make it, pay for delay it's called. But in terms of Celebrex, this is tied up in court right now, and it'll probably be next year, December 2nd, 2015, because they've got exclusivity for pediatric use. This is not new. Glucophag's going to do this. Metformin was going generic. Glucophag's got a 6-month extension to test the drug for type 2 diabetes in kids. So this is common. But if you read somewhere that Celebrex is supposed to be generic right now, and it was, it's not. It's tied up in court, and will still be for a while. Which brings up the concept of generics and lawsuits. Last November, the Supreme Court said that generic manufacturers can independently update the label. Heretofore, the label was written for the brand name drug by the company, and it didn't change. Once it goes generic, we're not really interested in it. And if there was a change, the generic company was not able to make that change in their labeling, and therefore were not responsible or legally responsible for failure to warn about a problem. Okay? And let me show you how that has played out. In Indiana, a lady had her hand amputated because they had used wrist veins to inject promethazine. Hopefully you learned in nursing school you don't use wrist veins for promethazine. You get small amounts, you dilute it, etc. Feminine can be very irritating. She sued the manufacturer, and her case was thrown out of court. She sued the generic manufacturer for promethazine, and they said, no, they had no duty to warn about that because it was generic. However, in Vermont, a lady was given Phenergan brand of promethazine, had her forearm amputated, and she collected $6.8 million. So this is why the Supreme Court has gone in and said, wait a minute, that's not right. So they have changed that. You ever feel like this little lab? Oops.
What a smart man.
Okay. Comments, questions on that before we go on? All right, I want to share with you, take a few minutes here to show you what Medscape, which is a program, it's a free program. You log on medscape.com. They get most every day they have updates and stories. But they have every January or December the top big stories of the year. So here's what they said last year. We got major drug alerts with antibiotics. A lot about antibiotics in the news. Resistance, for sure. We'll talk more about that later. 3 things. Azithromycin, risk for torsades de pointes. That's a cardiac arrhythmia, QT prolongation. Quinolones, increase in peripheral neuropathy and arrhythmias. And clarithromycin or Biaxin with calcium channel blockers, rapamycin, procardia, etc. Increased kidney injury, hypotension, and death, and cardiac arrhythmia. So most antibiotics today, except maybe for the penicillin, are associated with cardiac arrhythmias. And I'll share more about that with you in a second. The clarithromycin calcium channel blocker interaction, again on kidney injury, was a fact, particularly because Biaxin, as well as erythromycin, which we don't use much anymore, are very strong inhibitors of the P450 system in the liver that metabolizes other drugs, specifically CYP3A4. So if you inhibit that metabolism of breaking down drugs that are metabolized through that system, you increase their level significantly. So the level of the calcium channel blocker went up significantly and can cause hypotension, decreased renal perfusion, cardiac arrhythmias, etc. As much as 50%, so it's almost like 1.5 times the dose. There are also cardiovascular events with clarithromycin used for lower respiratory tract infections, particularly COPD, community-acquired pneumonia, etc., increased cardiovascular events, arrhythmias, etc. This was on Medscape. A Danish study in the British Medical Journal said that clarithromycin increases the risk of cardiac arrhythmias, 76% higher risk over what you saw with penicillin V. Fluoroquinolones, that would be Levaquin, Cipro, Avalox, Naroxen, etc. These all can cause peripheral neuropathy. Okay. Also, cardiac problems, heart failure, QT prolongation, those things are associated with quinolones. Probably the most significant of these is azithromycin, simply because it is widely prescribed. Z-Pak. or Zithromax. Now, I want you to follow and listen here because I want to ask you a question. And I wish this was working, but we may come back to it. 2012, in May, the New England Journal published the results of a study done at Vanderbilt in Nashville on the TennCare population. TennCare is Tennessee's Medicaid system, okay? So they took TennCare patients that were on azithromycin and found that they had a small increased risk for sudden cardiac death compared with amoxicillin, Cipro, with no antibiotic at all. Okay, that was 2012 in May. In March 2013, not quite a year later, the FDA officially warned of that risk. So it's been in the literature, but the FDA in March said, we feel that this warrants a warning, not a black box, but a warning that patients are at risk for azithromycin-induced arrhythmias, particularly if they have prolonged QT, low blood potassium and magnesium, arrhythmias, etc. Elderly patients may also be at risk. So, as of March 2013, the FDA had warned of this. In 2014 March, a year later, we had a U.S. VA study compared amoxicillin and azithromycin, greater risk of mortality and arrhythmia with azithromycin on days 1 to 5, but not 6 to 10. Now, how is azithromycin usually dosed? For how many days? It's usually for 5 days. So there was a risk. Levofloxacin levaquin was dispensed 10 days, resulted in an increased risk throughout. So 2012, 2013, 2014, we've had a report, 2 reports in the literature, and an FDA warning. Then we had the New England Journal in 2013 going back, saying there was no excess heart deaths for azithromycin in the Denmark study. This is the first of several that today that I will go over with you, where we have conflicting data. Folks, this is one of the most interesting and frustrating elements of trying to use evidence-based medicine in the literature to make a clinical decision. They said that the TennCare study was not a normal population. Now, one can argue, does socioeconomic class make a difference? Pathological, etc. I don't know. Or sicker, whatever. So you now have FDA warning, 2 articles saying it does, and 1 article in the New England Journal saying it doesn't. The FDA then tried to clarify this with that Denmark study that came out, and they said you got to keep this in the appropriate context. Other antibodies can cause arrhythmias, quinolones, etc. And they did add heart rhythm problems is already a precaution in the PI. So my question, and I'm getting ready to tell you a real world story, is does this impose legal implications on the nurse practitioner and or the pharmacist? Okay, think about that, and then let me tell you the story. In October of 2013, just less than a year ago, father took his 3-year-old daughter to a walk-in clinic near Nashville. The nurse practitioner had seen this little girl once before, had noted in the chart that she was being treated at Vanderbilt by a cardiologist for long QT syndrome. Yet the child had a respiratory infection. The nurse practitioner prescribed Zyrtec syrup, antihistamine, and azithromycin suspension. The father, now this is all allegations, we don't know these for facts, okay? The father said he specifically asked the nurse, is this drug, are these drugs okay for my daughter because as you remember, she has long QT syndrome. The nurse practitioner allegedly said, "Oh, I don't know, and I'll check them." The next thing we know, there is a prescription filled at the pharmacy close by. We don't know whether it was taken there, transmitted electronically, faxed, we don't know. And on the face of the prescription, it said long QT syndrome. Okay? The pharmacist filled it. We don't know if the dad said anything to the pharmacist or not. Took the prescriptions home, gave him Zyrtec, gave him erythromycin that afternoon, went down to do something. She was playing in the room. Suddenly the room got quiet and went up, and she was dead. So obviously there are going to be filed a lawsuit. And the question is, what is the liability, if any, of that? And so I asked two questions. And if you don't mind, Bill, I'll get this working. Were you aware of that warning before today? Anybody? Okay, so about half of you were aware of it. Okay. Then the next question, more critical, is do you think it's your legal responsibility to have been aware? Those of you who were not aware of it, do you think you can go into court and justify your reason for not being aware? Think about it. I won't ask for a show of hands. Now, I can say, yeah, the FDA issues hundreds of warnings every year. Then you could say, I work primarily in the area of contraception. I don't prescribe antibiotics. Well, sometimes you treat infections, and sometimes you probably get azithromycin. So that's going to come back to home. That's another reason I talk more than just about birth control, okay? Also, you can say, oh, but I read in the New England Journal 2013, the Danish study said that there was no association. And the FDA had a warning, but there's all kinds of warnings on every drug. And they said, keep this in context, other drugs can cause it as well. So I think it is defensible, but I think it will be a lawsuit.
Erythromycin is generic. So
Yes. That's going to be another one. Azithromycin is generic. So here's the question I'm asking of the pharmacist. Was that warning in your computer system in October? And is it printed out on there? Or should you have been aware? Or was it in that package insert? There's just going to be a very interesting lawsuit. It's going to probably set some precedents on what you should know. I'll admit that when it comes like to oncology drugs, hey, I don't even attempt to answer questions. I call Aubrey Waddell, who's our oncology pharmacist on faculty, and I turn everything over to Aubrey. You cannot possibly be an expert on every single topic. But what is your duty to do is the question that is coming up, and it's probably going to be a big thing. So, in that case, let's assume that that child was allergic to penicillins. Can't give them augmentin or amoxicillin. Well, you give them a cephalosporin. Well, there's a small cross sensitivity. It's very small, but it's there. Erythromycin is just as bad, or worse. Viaxin is just as bad. Quinolones are contraindicated in kids. So what are you going to do? Tetracycline, doxycycline is contraindicated in kids. So those are the defense mechanisms for this particular case. The other thing is, if you warn patients, they don't take it, then they get overwhelming sepsis and die. Because you told them that there's this slight possibility. It's just, with today's environment of the access to the knowledge that we have, It's kind of frightening to do. Kind of like blood clots with contraceptives. You want to warn every patient, smoking, I'll cover all that stuff. Okay, what else? Big news on supplements. For many, many years, take your calcium for good osteoporosis. Now, take your calcium, you get a blood clot, you get a kidney stone, and then you get cardiovascular buildup, calcinosis of the arteries, etc., and you're going to die. Higher all-cause and cardiovascular deaths, but not from stroke. Antioxidants are more likely to cause cancer than prevent cancer. That's the latest finding on Medscape. Meta-analysis, calcium increases the risk for MI. We don't know exactly how, but it does increase mortality, renal failure. So, how much do you tell your patient to take? 1,000 to 1,200 is the general recommendation. Get it for diet. Here are the specific recommendations for the age groups, for calcium and vitamin D. You see that the only way to go over 1,500 is if you're pregnant or corticosteroid, prednisone type drugs. Other than that, keep it to 1,200. You go to Australia, you know what the maximum recommendation for calcium is to Australian patients? 700 milligrams a day. Okay? We have one of the highest recommendations in the world. Maybe we're giving too much. I don't know. As soon as we back down, then we're going to increase the risk of hip fractures, and then we're going to die from that, and we're saying we need to take more calcium. I guess the point is, take 1,000, 1,200 maybe a day. Eat a good diet. But there's no reason to take 2,000 or 3,000. You know, some patients operate under the auspice if a little do a little good, a lot do a lot good, and that's not always true. What about vitamins and supplements, minerals? Do you take a Centrium every day or one a day? A lot of folks do. I do. I don't always eat the best. I don't eat a lot of red meat. I run every day. I can get anemic. So I take a Centrium just to make sure I'm getting plenty of vitamins. This article in Internal Medicine said I'm wasting my money. Now, I don't agree with that, in that what he's talking about in this editorial was that people think vitamins make them healthy, make them feel better. I know that. I have biochemistry. Vitamins just catalyze biochemical reactions. So what he's saying is that some people take a Centrium every day and then say, hey, I need anything I want. I don't need to exercise because I'm taking the vitamin. That's going to protect me. And that's where the fallacy comes in. So if you're doing that, that's not good. But if you're taking one just to supplement your diet, if you don't eat a good balanced diet, I don't see any harm in it. I don't take excessive amounts. I don't take mega doses, particularly vitamin E, although I've got something to share with you on that. Back 30 years ago, vitamin E cured everything, and then above 400 units a day, and I used to use 800 or more for fibrocystic breast disease. Now that'll kill you. Then a study, in case you don't get to it, 2,000 units a day decreased the decline in cognition in Alzheimer's patients without any cardiovascular toxicity. So, you want to take a lot of vitamin E? It's okay again now for Alzheimer's. DSM-5, that was another big story. Diagnostic Statistical Manual. This is the book on which we diagnose and treat psychiatric illness. It was updated from DSM-4R, the revised DSM-4. So this happens about every 8 to 10 years. There's a lot of concern that DSM-5 will result in mislabeling of potentially millions of people who are basically normal. That's what they say. Examples. Normal grief, which for the last 5 years, every Saturday afternoon I have suffered normal grief from the University of Tennessee getting beat in football. We don't even talk about basketball. lost our coach and stuff. Anyway, we got a new coach. Things are going to get better. But my normal grief on Saturdays under DSM-5, based on my symptoms, would be major depressive disorder. Forgetfulness is now mild neurocognitive disorder. You like this one, folks? DMDD is a mental illness. And DSM-5, I'm not teasing. Premenstrual dysphoric disorder, bad PMS, is a mental illness. You are mentally ill if you have it. A child with temper tantrums has disruptive mood dysregulation disorder. Are you ready for DMDD to go along with ADHD? Do you think there'll be a drug coming out for DMDD very soon? Of course we do. Because we now have a diagnosis for it. So Dr. Francis, who by the way was the editor of DSM-4, is very critical of DSM-5. He said, this thing I did everyday life doctor actually undiagnosed psychiatric illness, chemical imbalance requiring solution pill form. Either he's maybe right or he's just mad because they didn't ask him to edit DSM-5. I don't know. But very interesting. This is going, it's been out about a year, and it's already created a lot of controversy in the psychiatric field. There's a senior cell phone. My mother is 92 years old. She's still doing well. According to her genes, she's still got a few years. My maternal grandparents, her mom and dad, were married 81 years. With a national record for several years. 103 and 99 when they died. So anyway, mother's still doing good. Her older sister, who's 95, takes care of her. She's in better health than her. But her cell phone went out. And she had it for a long time, simple little flip phone thing. And so I tried to charge it anyway. So I took it to Verizon. And I said, have you got the same thing? And the guy just laughed. He said, we haven't made those in years. And he said, I said, well, it's for my mom. She said, well, can she handle a smartphone? I said, this was what she would really like to have right here. But I said, as simple as you can get. And he said, well, this has this camera. I said, she just wants to talk. And I'll program it with my number and my sister. She still dials or punches the button. But anyway, we found one. He said, this is the last one I had. I said, okay, thanks. But that should last her the rest of her life. Some other big news. Cholesterol guidelines from the American College of Cardiology, American Heart Association have totally revolutionized how we approach hyperlipidemia. Abandoning LDL targets. What was it? Got to get to 70 if you have two or more risk factors, 100, 140 if you have no risk factors, etc. Treat to the goal. Treat to the goal. That's no longer recommended. Gone are the recommended LDL, non-HDL cholesterol targets. This was published in Circulation in December. The association did focuses on prevention of atherosclerotic cardiovascular disease, no LDL targets. Again, I'm not going to get in depth if you are taking a statin or whatever. You need to really dig into this. But they're talking about now appropriate intensive statin therapy. You would think maybe that abandoning the dose would decrease statin use. No, it's projected that over half of all Americans over the age of 45 will be on statin under the new guidelines. Right now, it's about 25%. Healthy lifestyle is also talked about. Again, prevention, diet, exercise. Big change in exercise. Used to be 20 minutes 3 times a week. It's now 40 minutes 3 to 4 times a week. Recommendation, minimum. Every day is preferred. Now, using body mass index, BMI, That's a good thing from the standpoint of all the new obesity drugs that we'll talk about are approved based on BMI of greater than 27 with 2 or more risk factors, or 30 with no risk factors. Although if you have a BMI of 30, you've got some risk factors. But anyway, we're using BMI more so. Still though, waist circumference is the best indicator of cardiovascular disease and diabetes. So we use both. We got a real problem with these, I'll come back to later. Half of the population, 40 to 75, will be on statin, according to the New England Journal in March of this year. Now, not everybody agrees. Here's another controversy. The American Association of Clinical Endocrinologists, AACE, my neighbor across the street is an endocrinologist that specializes, he calls himself a lipidologist. He's board certified lipidologist. I didn't know they had such a thing. They did. Okay. And he talks about the fluffy particles and all of this and all these things way beyond just LDL and HDL. He considers himself in this group to be the experts on lipids, not the American Heart. I'm never concerned about a lot of other things. This is the one that said, we are the lipid experts. What do they say? You need to go back to the basic guidelines in 2012 and stick to the codes, 1700, etc. So, depending on who you work with, what cardiologist, internist, lipidologist, or whatever, there may be a totally different approach. So, movement is toward not treating to a goal, but not everybody agrees with that. So, it's the best evidence we have. The other studies are not evidence-based, but they do not represent exclusive methodology, and they're not a replacement for clinical judgment. There's the floor sign that came out at advertised. So, they left the compensation, they're called JNC 2013. Because previously, about every 7 years, they had a report of the Joint National Committee on Hypertension, etc., that met, and here are the new guidelines. Just to share with you, I was actually at JNC 1. Not one of me. I didn't know I was. Didn't know that's what it was called, but I was in school in Memphis, my final year. I remember one of my instructors said, then they're having some kind of meeting down at Peabody about blood pressure. Go down there and see what it is and you report back to the class. So I went down to Peabody, saw the ducks and all that, and listened to what they said. It was about a 2 or 3 hour meeting. And basically it was everybody diet and exercise. Then you start on 50 to 100 milligrams of hypochlorothiazide. And then you can add hydralazine, but hydralazine can cause a reflex tachycardia. And there's this brand new drug that just came out that you can give to offset the tachycardia caused by the hydralazine. It's called propranolol or Inderol. Back it was 1969. I mean, should have taken pharmacology a long time ago. It was easy. So you have propranolol. If that doesn't work, you add albumet, methyl-dopa, or guanethidine. That's it. You said, well, what about ACE inhibitors, calcium blockers? We're talking 80s and 90s here, folks. In those days, it was simple. So, we now have JNC 8, JNC 2013. That was published in JAMA in December. Questions that they were looking at: does initiating drug treatment, specific blood pressure, improve health outcomes? And you say, well, of course it does. Show the evidence. See, we're entering this evidence-based medicine. We want evidence-based. Well, we know that lowering blood pressure increases health outcomes. Do we really? It's kind of like, do we know that getting to 70 increases outcomes? LDL. So we're beginning to question what we're doing. Again, do you have to get to 120 over 80 or 140 over 90 or what these numbers are? Are there differences in the drug? What they recommended, particularly for us old folks, is you don't need to be treated as aggressively as previously thought. You take my mom, she's great health, except she takes 4 different antihypertensives. Her blood pressure spikes up into 190 over 100, 110. They call from the assisted living, and she's out. Your mother's blood pressure's up today. I said, well, take it again. Oh, it's 120 over 80. It just spikes for some reason. We don't know. We don't take her to the emergency room every time it does that. To drop her to say, oh, we've got to get you to 120 over 80, she would be in shock. And the same way with diabetes. We'll talk about in a moment. So we're not nearly as aggressive. Older folks, 150 over 90 is fine. If you keep them around that, don't get too concerned. Other groups, 140 over 90, but that's the definition of hypertension. Well, that may be what we want, including diabetics. We used to, oh, diabetics, you've got to be lower, not necessarily. Chronic kidney disease used to be 130 over 90. What about the type of drug? It's always been thiazide diuretic. And then a few years ago, American Heart said, don't use beta blockers first line. So what are the new guidelines? 4 classes of drugs are equally recommended. ACE inhibitors, ARBs, calcium blockers, and thiazides. What does that mean? You don't have to start everybody on thiazide diuretic. You can start someone on an ARB. 4 years ago, that was not the case. It was done, but there was the evidence for it. Beta blockers are no longer recommended for initial treatment. There's still a ton of beta blockers used for treating high blood pressure. They're good drugs, but we don't start patients on those in most cases. A lot of side effects, a lot of adverse events, etc. That we have. In the black hypertensive patient, we may treat them a little bit more. We recommend a calcium blocker or a thiazide as initial therapy. ARBs and ACE inhibitors don't work quite as well in the African American population as they do in the Caucasian or Asian population. If you want all the data that this is there, I know you probably can't read it, but these are all the different studies and the recommendations for initial treatment. So that this is a condensation of all of those different ones. What if you don't reach the goal? You can increase the dose or add a second drug from another class. If you don't get to 2, add 3. The only thing we do not recommend is using an ACE inhibitor and an ARB together. That can be a double whammy to the kidneys and so 3 drugs is not unusual. If you add a 4th, it's usually something like clonidine. It's fairly common from those classes. Are the JNCA guidelines for high blood pressure misguided? Again, not everyone agrees. This is cardiometabolic disease source questioning this data. So you're not going to get 100% recommendations or anything. Other big stories. Obesity is declared a disease. Now, there is a diagnostic code for it. It makes it easier to get paid for the anti-obesity drugs. It recognizes it as a disease. And that's not really new, but it is from the medical standpoint. It's not new in the understanding that we have because Shakespeare, 400 years ago, here I'd share a little. I'm not just drunk. Shakespeare said, the grave doth gape for thee thrice wider than other men. You like that? That's pretty heavy. If you're 3 times bigger than somebody else, you're going to die sooner, is what Shakespeare was saying. So this is not something new. It's just that it is now recognized as a disease by AMA. Another big story. How many of you have heard of fecal transplants? If you're in a hospital, you've probably seen it. For treatment of C. diff diarrhea, they are actually transplanting feces from a healthy donor, either an NG tube or a rectal enema type thing. They're working on a encapsulated fecal material, so to get that normal flora built up, etc. But C. diff is serious. By the way, the hand sanitizers do not kill C. diff. That's nursing 101. But anyway, this is called FMTs, fecal microbiome transplantations. And they are doing this in some hospitals. This I'll show you because Sugar and Spice last winter, they did not want to go out in the snow. They're lowriders. You know what I mean? He said, boy, you think you've got problems. Questions on those big stories. I wanted to get those in if I got nothing else in. That's going to get you pretty well on what happened, but I've got a lot of other stuff. Okay, let me share with you a little bit. I know that I think you have to have so many credits or something in prescribing controlled substance and chemical dependency and drug abuse. So this is not a lot new from what I covered last year. So I'm going to go pretty quickly through it, but I want it to suffice for your needs. If you go back to the history of the drugs in this country, we've only had about a little over 100 years of history. 1906 with the Pure Food and Drug Act, it was set up just to prevent adulteration of drugs. They have to be labeled as to what's in them. Here's an example. One night cough syrup. That's probably a good name when you see what's in it. Alcohol, cannabis, marijuana, chloroform, and morphine. You think that would treat cough? Only just one night. But folks, there were things like that, and you say, but didn't somebody control it? Yeah. The FDA said you got to put on the label what's in it. And that was the only control. It didn't have to be safe, effective, or anything else. Then in 1914, they said we could tax. That's a unique idea. The government taxing narcotics. 1938, safety became an issue. A lot of kids were killed taking elixir sulfanilamide that was actually made in Bristol, Tennessee. 1952, they separated over-the-counter from prescription drugs except for opiates. I always say that in pause because the young folks say, what? And in 1952, we didn't have any drugs. I'm serious. Most 99% of the drugs we use today came along in the late 50s, 60s, and on that. Digoxin or serpine, morphine, that's about it. 1970 was the Controlled Substance Act. Set up 5 schedules. Schedule 1 had no legitimate medical use in the United States. LSD is an example. Heroin is an example. Now, on the other hand, heroin is used in other parts of the world, Great Britain. Heroin simply, this is a little medicinal chemistry for you. If you take morphine and add 2 acetyl groups to the carbon atoms, you make diacetylmorphine. That's heroin. So it's nothing different. It's a good drug. Just we don't need another analgesia. We got Dilaudid, we got oxycodone, etc. Heroin was introduced in 1897 by the Bayer Company. At the same time, they introduced aspirin. And both heroin and aspirin were used as cough suppressant, or heroin particularly, and to treat morphine addiction. Think about that. Yes, did it work? Of course. You laugh, but we do the same thing today with methadone. Methadone is an addictive substance. You just switch in the addictions and then you live off that. Schedule 2 has the highest abuse. If you haven't heard, most of you have, hydrocodone is now Schedule 2 as of October the 6th. So you've still got another 2 weeks. It comes Schedule 2. Sunday morning, going into church, the greeter was my dentist. And I said, hey, he said, come here. He said, what am I going to do now? What am I going to call in for pain? Yesterday, get in the car to drive here. My cell phone rings. Thus far, this is name's oral surgeon in Memphis. I was given her name by some friend of mine. Said, what am I going to do now that hydrocodone is scheduled to? This is just in the last 2 days this question is big. You can no longer call it in. You have to have written prescriptions. So what have I been telling them? Tylenol number 3, codeine. Well, the oral surgeon said, yeah, but my patients say it causes nausea. It does. That's the advantage of hydrocodone. That's nausea. I said, well, maybe add a little about 12.5, 25 milligrams of promethazine or phentermine too. He said, oh, that's a good idea. Or tramadol, Voltaren, might work. It's Schedule 4. But nothing is going to be as effective as oxycodone or hydrocodone. So, it's going to be a problem. So that's this fact that hydrocodone is now scheduled to as of October 6th. You think that's a good idea? Just raise your hand. It's a good idea for trying to reduce the abuse, but it's going to cause all kinds of problems for legitimate pain treatment. Just as, you have oral surgery, they give you 12 tablets, and you need another day or two, and you're not addicted or anything. You've got to go in and get a prescription, or they've got to mail it, or whatever. So it's going to be a problem for legitimate. It's going to hopefully reduce the abuse of it. Schedule 3, codeine products, antibiotic steroids. Schedule 4, all benzodiazepines as well as carosocanol and tramadol. So you're probably going to see an increased use of tramadol. You did after propoxyphene, Darvocet was taken off the market. Tremendous increase in the use of tramadol. Don't think, however, that that's not also causing dependency. It does. What we see in the hospital all the time, we're catching up with it now. Patients come in that have been taking tramadol for osteoarthritis pain or whatever, and they do a drug history and nobody recognizes that that's a controlled substance. Or if they're taking hydrocodone and codeine, we know, well, they don't get anything, and they sit there and they're doing this. They're withdrawing. So don't cut that short. Schedule 5 has release potential. You get codeine cough syrup by signing like you do for pseudoephedrine. Low motor, Lyrica, very little abuse. I've never seen a low motor ad. Let's put it that way. This was in the Knoxville paper last Easter weekend, which kind of is, if you tilt that X up, it's across, etc. And it says a prescription drug problem we need, and particularly in East Tennessee, we've got a real problem. Southeast Kentucky and East Tennessee are the headquarters for it. The U.S. is the biggest opiate market in the United States. Look at this. This is CDC. We prescribed enough painkillers in 2012 to give every American a full bottle of opiates. I didn't take any. If somebody got 2. Now, 3 years ago I did. I took 2 tablets of Percocet after shoulder surgery. And I'm glad we've got Percocet. And they had prescribed 36 tablets. I took 2 of them. I've dumped the rest of them out. I don't want those in the house. Alabama, Tennessee, West Virginia, Kentucky's not far behind as far as the biggest market. More than any other nation. However, with the Controlled Substance Monitoring Database, it's called CASPER here, in Tennessee, it's the TCMSD, whatever, 36% drop. So we've decreased the amount now that we know who you are, where you got the field, etc. Overdose is the leading cause of accidental Tennessee deaths, more than car accidents. People overdose every day. I think I may have shared this with you last year, but it's worth repeating. We had a tragic situation down in East Tennessee, Granger County, where a former police officer, sheriff's deputy, went into he was addicted, and went into a pharmacy, demanded the oxycodone. It was given to him. As he was leaving, I guess he's come to realization, hey, they know who I am. So he turned around, shot and killed the pharmacist and a person in the store buying some toothpaste, and then attempted to kill the 2 technicians, but missed and ran out. They apprehended him. They just gave him life in prison just a few months ago. In response to that tragedy, the sheriff of Knox County, J.J. Jones, said that 98% of crime in Tennessee is related to the drugs. That's astounding. But if you think about it, those robberies, break-ins, car burglary, used to buy drugs, etc. So that is a problem. We've got traditional categories of drug abuse: opiates, benzodiazepines. If you're not familiar with all of these, you can look at them. If you look down here, the average addict uses about 20. I've seen as many as 30 tablets of hydrocodone a day. One tablet puts me in a state that I can't hardly function. I've seen people taking 30 tablets a day, walking around, you never know. That's called tolerance. Tolerance is one of the most amazing pharmacological things that occur. It is amazing what we can see. Other things, stimulants. We're going to talk about Adderall and Ritalin in just a moment. Sudafed, antipsychotics. They're not controlled substances. People don't like to take them if they're taken legitimately, but they do really like to get some Seroquel if they're coming down or withdrawing, coming down from a cocaine or a methamphetamine high or withdrawing from opiates. That will really help kind of settle them down. Muscle relaxants, particularly carisoprodol, but you can see Flexeril and others abused. Anticonvulsants. Neurontin is not controlled. Pregabalin is a Schedule 5. But if you give gabapentin, if you snort it, it gives a high similar to cocaine. I'm not talking about people who take a capsule of gabapentin. I'm talking about flushing several out and snorting or injection. That's the way people do it. Other things, they'll abuse antidepressants. That helps withdrawal from opiates and cocaine. They'll abuse antihypertensive. Clonidine is sometimes abused because it causes one sedation. Beta blockers will help with tremors, tachycardia, etc. So again, most any drug can be abused. You think of opiates and benzos, but the others can. Other things, antiemetics, promethazine, is a similar CNS effect to alcohol, reduces the nausea that occurs with the opiates. You as a nurse would give a lot of morphine, they throw up. Hopefully they go to sleep first. That's why we give promethazine with it. Use Viagra, see, there's a new one, stimulant. Think about that name in just a second. These are used to offset the erectile dysfunction, etc., that comes from opiates. You may or may not know, opiates cause lower testosterone levels. They use anti-estrogens. I've got a slide on that in a little while to prevent gynecomastia. You say, well, those are used to treat breast cancer. Yeah, but if you're taking anabolic steroids or testosterone and using that, the testicles shut down, you get estrogen override, and you get gynecomastia. By the way, I don't want to insult your intelligence. I'm not intelligent. But my language here, but they call gynecomastia on the streets known as bitch tit. So if you hear that term from a man, that's gynecomastia. Sedative, I say that with the last. Who would abuse Tagamet? Why would you abuse Tagamet? Tagamet is much like Miaxin and erythromycin that we just talked about. It's a significant inhibitor of the P450, 3A4 system, which metabolizes a lot of these drugs. You take a Tagamet and you slow down the metabolism, you increase the levels. Okay? Do one break here. We got a few more minutes. The Casper system. How many of y'all use this? Okay, if you're writing controlled substance prescriptions, you should be. In Tennessee, it's a law. Is it law in Kentucky that you have to? Okay. One of the problems is only those authorized by law can access that information. Now, it's my understanding in Kentucky, law enforcement does have access. Is that correct?
Yes.
In Tennessee, they do not. And they don't like that. Okay. One of the problems with all these databases is they're not all the same. Tennessee allows 2 extenders, we call them. You can appoint MedTech or Pharmacy Tech or whatever to access that on your behalf, on the provider's behalf. Georgia does not have that. So if you live in Chattanooga, you go right across the line down to Dalton, Georgia, buy some carpet and then buy some hydrocodone, and they don't have access, and it's a different system, etc. This is right off the Casper website, so you probably know more than I do about it. But you get all these reports, and they are very helpful. I'll share some of that with you. The source of information, who wrote it, law enforcement can do it. It's not intended to prevent folks from obtaining the drugs and if those decrease. Who can obtain that? As I said, law enforcement, attorneys, etc. This is different than other states. This question you probably would have got, which is not one of the top 10. That would be Carosoprodol, but it was also number 11. This is the top 10. Hydrocodone is number 1. Oxycodone, alprazolam, that's Xanax. Then we have clonazepam, Ultram, diazepam, Ribavirin, Adderall, phentermine, lorazepam, methylphenidate, and I think number 11 was Carosoprodol or someone. I know it was in Tennessee. This is Tennessee's, almost identical. We have buprenorphine, Subutex, Suboxone, is our number 10. Can you provide, prescribe, and control substance to yourself? You know the answer to that one? You can prescribe a Schedule 4 in an emergency. What constitutes an emergency? Where you would need Xanax? That's up to you. You cannot prescribe Schedule 2 or 3. You can't say, well, I've got a bad headache, I need some hydrocodone. You can call your friend, and as long as there's a legitimate provider-patient relationship, that is good. But just a friend, they might question that. So we're really restricting that. The quickest way to get in trouble with any board, regulatory board, is controlled substances. It's really a shame that's what we do. You have to write C2s on a separate prescription order. I mean, I appreciate some of these efforts to save paper, but you get a prescription of 10 drugs and a little line between, you can't read any of them, and then 2 of them are controlled substances. Those have to be filed separately, so you've got to make a copy and then mark these out and add this. So just write one, legibly, one prescription on each blank, or electronic prescriptions, or become the thing of the packs. We're into the texting generation. Let me see if we can. Let's just hold off. We'll pick up there. I want to see if there's some questions. We got 3 minutes here before lunch, but questions on anything we talked about. We'll come back after lunch, finish up the drug abuse, and then get into some of the women's care stuff. So questions on what we talked about thus far? Anything at all? Yeah.
You were talking about the oral surgeon and the dentist. I mean, I assume they can write the prescription. It's just that they don't have to rewrite it. Is that right?
Yeah, they can write the prescription, but what the dentist was talking about, he gets a call on Saturday, and somehow he's got to get that prescription to the pharmacy, or the patient pick it up and all that. But no, do the surgery, write the prescription for 12. Percocet or whatever, hydrocodone, yeah, that's fine. They get it filled just as they do. But if they need some extra, call it. That's what the problem. You can't call it, but you can write it. And in the old days, before DEA got so serious about stuff, as a pharmacist, you get called, give her some Demerol or whatever, and then we would stack the prescriptions each month, take them up to the doctor, decide. You don't do that anymore. Yes.
Here in Kentucky, we have some restrictions on nurse practitioner prescribing for Schedule 2.
Okay.
So we have limitations on how many days. However, there is a caveat because in last session, we had an amendment to that so that Schedule 3 drugs can be written for 30 days. And that's true, but the hydrocodone is still going to be, for nurse practitioners, a Schedule 3 accountability. It's going to be a little tricky.
That'll be interesting how they enforce
We
that.
still have, you can't call in,
Yeah.
but you can write that for 30
30
days.
days.
That's, most of us, if we're working in this state setting, we're not writing for any narcotic.
Right.
But if you work in another facility, or if you have other nurse practitioners that that's the caveat to that.
Well, thanks for pointing that out, because that's another thing that differs from state to state. Tennessee, nurse practitioners, PAs can write for any Schedule 2 through 5. Virginia can't write for any 2 or 3. In Kentucky, as I found out, there's some restrictions. So again, there's slight differences between each state, and you better check and make sure you know, because I can tell you the DEA are serious. They are going to address this issue of drug use. They are doing it. And we are seeing a decline. And that's good, except for the person with legitimate pain. It does create a problem for them, but they're not really that interested in that person. They're interested in decreasing the abuse. Other things, any other questions? Lunch ready? Wait,
One quick one, I'm sorry. You're talking about like they're crushing that and snorting it, and it's like a high cocaine.
While we're getting back in, let me kind of pause here and see if there's some questions you thought about over lunch or anything that we talked about this morning you want to mention again. If you notice, we're about a third through the time, and probably about an eighth through the slides. But as I said, I'll speed up some, slow down on some others, but I do want to make sure we get your questions answered. Well, let's continue talking about abuse. And I've already mentioned several things about opiate abuse, but one of the things we're finding that the restrictions on oxycodone being made into a abuse retardant formulation, and now with increased restrictions on hydrocodone, folks are turning to heroin. Heroin is cheaper, works just as well or better, and the problem is we don't know the purity. We don't know what it's cut with, how it's obtained, etc. We have also a drug called Zohydro that was approved last October. It ran into a lot of regulatory and legislative questions. What it is hydrocodone without acetaminophen and ibuprofen. So it's like OxyContin, which is just plain oxycodone in a sustained release form, but it has gotten the reputation of being some new drug. I've had lots of, what's in that new Zohydro? It's hydrocodone. No, they said on the news it was a new highly addictive drug. No, it's hydrocodone. It just doesn't have the acetaminophen ibuprofen, which reduces the abuse. This is extended release. Some states are banning it. Some states there's a move right now to make the company make it abuse retardant. So you're probably not seeing a lot of it. But I do have it working now on the clicker, so you can click in. What is your opinion on the synthetic hydrocodone? Good addition since it doesn't have acetaminophen, which causes a lot of liver problems. Particularly when you're taking 30 tablets a day, you die of liver failure. Well, likely to be highly abused, should not be prosecuted, or don't have an opinion. So everybody click in, see it right up here is responses are coming in. You can see it's working. So I'll let that go and see what you all think it is. Let's see here. 52% think it's good. Okay. Most healthcare professionals think it's a good idea because we're not having all these super benefits. But if you ask this to the lay public, particularly that's watched the news, oh, this is a terrible, addicting, bad drug. So I wanted you to know what it was. They've also approved an oxycodone acetaminophen combination. You say, well, we already have Percocet. But this is, Percocet is immediate release. This is immediate release and extended release. So it's IR and ER, and it's called Zartimus XR, and it is approved for acute pain. OxyContin is approved for chronic pain, not acute pain. It's long-acting. So this has both immediate and extended release, twice a day dosing of Zartimus XR. There's another one that has oxycodone with naloxone, Narcan, which is a narcotic antagonist. You say, well, why would you want to block the effects of the oxycodone? Well, if it's taken orally, the naloxone doesn't really have any effect unless you get extremely high doses. But if you crush it and snort it or shoot it up, it will block those receptors and you don't get any effect from the oxycodone. So this is an abuse retardant product. This is not new, though. Some of you might remember the drug Talon, pentazocine. The only way that drug has been available for the last 30 years is as Talon MX, which has naloxone, because people were crushing it up and shooting it. So, again, I'm surprised that we haven't seen this combination earlier. But that was just approved a few weeks ago as Tarnic XR. What do you think about, again, I need to move down, I think, but this from a patient being able to obtain naloxone and Narcan from a pharmacist? So many states, most states, have passed legislation on that. Do you think that's a good idea? No, yes, or under some circumstances? Pretty well split between good idea and some. The point is, that the thought is, if you have a family member, friend, who is abusing opiates, we're not condoning that. But if they overdose, by the time you go to the hospital, they're dead. So this way you can give them Narcan on the way to the hospital and perhaps keep them breathing long enough to be treated. Again, it's controversial in that it seems to be accepting drug abuse, etc. But it's, in my opinion, no different from having someone with severe allergies taking Epipen. You're not going to self-treat, but on the way to the hospital, you can save them. So the FDA has approved a self-injector of naloxone. It's called Vizio, and it is just like an EpiPen, or I think last year I showed you there is a new EpiPen, epinephrine delivery system. It's called AviQ. Looks more like it's a self-injector that to help talk your way through it. If anybody wants to see it, I'll demonstrate it at the break. But we're using a lot more self-medication, self-sustaining stuff. It costs about $600 for 2 injections. Huh?
Who's going to buy it? Who's going to spend that kind of money?
Who's going to buy and spend that kind of money? People with a child that is addicted to the OxyContin, just to save a life. Yeah. Not too many. It's not going to be a big seller, but again, it's very controversial whether to do it. But they are recognizing. New Mexico just passed laws saying that you had in Tennessee, in most states, you had to get a prescription for it, but in New Mexico, pharmacists can sell it to a person. I mean, if you give it to somebody, it's not going to do anything if they're not on opiates. Will EMS be carrying it? I would assume that they already carry Narcan, just not the self-injector. But I mean, they've got Narcan that they can inject. So again, a lot of these things are not new drugs. They're just make it more easily available to the lay person. Because in these emergency situations, as you know, 5 minutes can be the difference in life and death. I see a hand over here.
I was gonna say, we were talking about local policemen, and the policemen are gonna start carrying,
The policemen can start carrying it.
are going to.
Are going to. Yeah, that's again, I can see where that would be a good idea in most cases. I'm not opposed to that. I mean, I've gone through school teachers. It's interesting though, like my wife can administer rectal diazepam for a kid in a seizure, but she cannot give them an albuterol inhaler if they're having an asthmatic attack. That doesn't make sense to me. That's my understanding. Again, I don't know. It's kind of like head lice policies in schools. They vary all over the world. The Joint Commission, Hospital Accreditation, has issued an alert for opiates, and it's just to remind all of us how important these are. The focus particularly is on sleep apnea in obese patients. What we're seeing here in the last few years with the growth in obesity and sleep apnea is patients dying, and they're saying that they were given too much opiates. Well, we have to give a larger dose for a larger person in most cases. They have risk, so it's resulted in a lot of lawsuits. So we need to be careful. The other sentinel event that they're talking about is the person who does not recognize that there's a significant difference in the dose of opiates. For example, patient's been on 12 milligrams of morphine, and they're going to switch to Dilaudid, and they give them 12 milligrams of Dilaudid. Now that's about 6 times more potent. That's about 2 milligrams of Dilaudid, or less, and they die. So those are what we're talking about. I mentioned DSM-5. The diagnosis criteria for drug dependence has been strengthened. Used to only one symptom for mild substance use, now requires 2 to 3 symptoms from the following. And most of us can read through those and find that many of our patients meet the criteria for drug dependence, whether it be mild, moderate, or severe, for that. Continuing to use, puts you in danger, impairment, tolerance, etc. So the point I'm making is, like I said before, there's a difference between dependency and addiction, but most patients are going to be classed as dependent if they're taking opiates on a chronic basis. That doesn't mean they're addicted, but they're dependent on it. Treatments for opiate addiction, dependency, we got methadone. I mentioned that previously. It's just swapping the addiction. Methadone is in treatment. It's used for pain, but it shouldn't be used above 40 milligrams a day for pain. The FDA has warned against that. The reason being its half-life is very long for the terminal excretion half-life, but the pain relief half-life is very short. So you tend to need more, and it accumulates and can cause rhythm disorder, respiratory depression, etc. When used for treatment of opiate addiction, it has to be done in a state-certified clinic, which entails that the patient drive or be driven to take an observed dose. Every now and then they'll get to the point that they'll give them some home medication, but most folks will be selling it. And that always creates a lot of consternation about taking a dose of methadone. You can go up to 200 milligrams in a clinic. Most of them are on the 80 to 120 range. Then they get in the car and drive home. Now they're tolerant, but still there could be involved in automobile accidents. So a lot of folks have gone to buprenorphine. Subutex is buprenorphine plain. Suboxone is buprenorphine with naloxone or Narcan in it. This requires a special DEA number and certification to use buprenorphine for opiate addiction treatment. You can still prescribe buprenorphine for pain just as you can methadone. Now, the difference is this is a similar drug. They're both opiate type drug and are abused. People abuse methadone, people abuse Suboxone. The Suboxone has the naloxone to prevent it from being crushed and snorted or injected. But it can be done in an office treatment, so you can write a prescription for 30 days or 60 days or whatever, and have them treat themselves. They don't have to drive to the clinic every day to get it. But keep in mind that this drug, like methadone, is also can cause dependency and is abused. So that just talks a little more about it. This is kind of a nice slide to sum up, particularly pharmacists like this. Said, I don't always try to refill my hydrocodone early, but when I did, it's because the pharmacy shorted me and they dropped a few that weren't, and I dropped a few that weren't, stolen down the sink, and I was on my way out of town for a funeral, and my doctor said it was okay. And that's pretty much the excuses that pharmacists hear about refills. And this is another reason that hydrocodone was Schedule 3. We won't have that issue anymore. I take a new prescription each time. We do abuse benzodiazepines, going back to the 60s with chloride epoxide, Valium, Ativan, oxazepam, chlorazepate, not used a lot. The big one today is aprn1. I do a lot of legal consulting on effects of drugs. The most common thing I see on drug screens are hydrocodone or oxycodone, alcohol, and aprn1. I mean, that's the cocktail. They had carosoprodol somewhere in there somewhere. Highly abused, but a highly effective drug. Somebody having a panic attack, whatever, it's a great drug. Anxiety, 0.25, 0.5 milligrams, up to even larger doses for panic attacks. They give 8 milligrams a day, etc. Most people on half a milligram a day do well on it. But like any other drug, people like to increase the effects. It is abused. A couple of things about this, and I think I showed this last year. It comes in 0.25, 0.51, and 2 milligrams. The most popular are the 2 milligram tablets, and because you can break them down into 0.5, 5, 1.5, or 2. They're stored. So since they are stored, they're sometimes called tombstones, ladders, bricks, bars, totem poles, etc. By the way, don't get it mixed up with Boost Bar, which is not a controlled substance. It looks similar, so don't get ripped off if you're buying your crazy on the street. I know I told this last year. I told it probably 2 or 3 years, but about 5 years ago, my wife came home one day, second grade teacher. She said, what are totem poles? And so I was in kind of a mood, and I said, well, the Native Americans call it drugs. And I said, why are you, I said, it's 2 milligram aprn1 in Xanax, why are you asking? True story. She said, one of my kids today said, Miss Farr, my mama has some totem poles she wants to sell. Do you want to buy some? Now, you thought 7-year-olds just sold Girl Scout cookies. Okay? She was out pimping Xanax from her mother, 7 years old. So they did call DHS, it was investigated, etc. Carosoprodol or Soma, highly abused. This is not a new drug. Some of you might remember meprobamate, Equinil, Milltown. That was the Valium in the 50s. We no longer market meprobamate, but you can appear real smart if you get a call from a lawyer representing a person that's been involved in a car wreck at a drug screen. I get this all the time. How can I swear the only drug he took was a muscle relaxant, Soma, and I looked that up. That's carosoprodol. But there's 2 drugs on his drug screen. I said, let me guess. The other is meprobamate. Boy, you sure are smart. No, I'm not smart. Carosoprodol is metabolized to meprobamate. So we're making the same drug. For many years in Tennessee, carosoprodol was not controlled. It is now. It's Schedule 4. All the contiguous states it was controlled. It's always been amazing to me. Meprobamate has always been a Schedule 4 drug. Whoops, I'm hitting this thing. Always been a Schedule 4 drug. And, but carosoprodol, its precursor did not. You see what I mean here? I don't know what I've done. Next. I know that. Let's see. What do I do? I'll tell you, this technology is something. Okay, now.
All right, let's
So it's metabolized to that. Let's talk about methamphetamine. Comes in several forms: crystal meth, ice, etc., powdered form. It causes a lot of problems. There we go. It's not very pretty. 10 year of meth use, same person. Same person. Also affects the dentures. I talked last summer to the Tennessee Dental Association annual meeting in Nashville. I showed this. There was a periodontist sitting on the first row. He said, "I can fix that." Okay. And I said, "Do you see this?" He said, "Oh yeah." You would think that a meth addict wouldn't go to this, but they do in some cases. And it's not a pretty sight. It affects the brain. This is the mother of all dopamine agents. Dopamine is what we like to have. It makes us feel good. That's why we eat, exercise, drink, smoke, sex. All these things, gamble, increases dopamine. Do the same thing with methadone on steroids. Big time pleasure rush from the dopamine. It does affect the brain. I won't get into all, I'm not a neurologist, but it does show differences in brain activity with meth. Normal abuse does show that it does linger and has an effect on the brain. They make meth from pseudoephedrine in most cases, although methamphetamine was actually an approved drug in the 70s called desoxyn, brand name. It was used just like we use Adderall and amphetamine with Dexamine today. It's still not marketed, but you can get methamphetamine tablets by prescription. But they use Sudafed to make it in there. This is restricted. In Kentucky, the annual limit is 24 grams. In Tennessee, it's 5.7 for 30 days, 28 grams in a 1 year period. So each state is different, is what I'm trying to say. I don't expect you to know the total content. Federally, though, it is 3.6 grams a day. So there's all kinds of limits and things that we have to keep up with. Well, in actuality, this doesn't really matter. You show your ID, you buy the amount. Now this is, by the way, if you got a prescription, there's no limits. So if you buy a prescription for it, it's fine. The problem is if you have your daily limit, that's easily taken care of because the cookers just hire these people, called them Smurfs, and they go in and buy their quantity and meet out in the parking lot and dig it up, and they go cook up the meth. So it's a big problem even with the restrictions that we have. To try to address the abuse, they have come out with a product called Nexafed, which is kind of like the OxyContin today. It's abuse retardant. Doesn't mean it can't be abused. It's just more difficult. In Scott County, Tennessee, up on the Kentucky border, 75, 09, if you go, they have, all the pharmacies there have gotten together and will sell only Nexafed. They don't sell any pseudoephedrine products to try to reduce the amount of meth. But then go over to the next county and do it. This is a picture of bath salts. Pharmacist at Johnson City, Tennessee, sent me this. He found these two bottles out on the road in front of his house. Happy Hour, Wicked X, shows the contrast between the names. They're all the same. Some of them sound real innocuous, White Dove, etc. Bath salts, that's like bubble bath. What this is is, the closest thing I can think of is between cocaine, methamphetamine, and LSD. It's kind of, has a little bit of all of them. It's called cathinone, and here is the chemical name for it, form of metabolite. It's labeled as plant food or bath salts, and up until a couple of years ago, you could get them at the local convenience store or whatever. Today, you have to go online to get most of them, but you can still get it. 2 years ago, we had 5 people a day average going to Johnson City Medical Center, Southwest Virginia, Southeast Kentucky, Northeast Tennessee, that we're trying. 5 a day going for this. It's gotten better, but it's still a problem. You know, we do the rat studies and offer cocaine or food and whatever, they'll take the cocaine. They did this between methamphetamine and bath salts. Methamphetamine, the rats pushed that lever 60 times. The bath salts, they pushed it 600 times. 100 times more, or 10 times more pushes from bath salt than methamphetamine on the rats. Speaking of methamphetamine, I like dogs, as you know. Yellow lab, black lab, chocolate lab, and meth lab. It's kind of messed up. Other drugs, dextromethorphan. That's cough syrup. People use that? Yes. If you're looking for the next restricted drug after pseudoephedrine, it's probably going to be dextromethorphan. New York already has some restrictions. Most of the chain pharmacies require you to show ID to buy Robitussin D or anything with dextromethorphan. Why? It is an analog. Then again, I need one of these lavalier mics. What did I push for? There we go. There we go. It is an analog of codeine. Therefore, it does have some abuse, particularly in higher doses. Here's what the New York Times said about it several years ago. Dextromethorphan, or drinking just puts you in a stupor. Robitussin D makes you think you can fly. If you want to be amazed sometimes, well, here's all the ways it's available. Triple C, Robitussin, a lot of states have banned it. Google dextromethorphan dosing scale, and you'll get this. Okay? What this says is you want to get to plateau 1, 2, or 3. That's the level of euphoria, the level of high that you want to get. How much do you need to take? Well, no, you know, most drugs are milligrams per kilogram. If they go one better, they give you that. They'll give you milligrams per pound, because most folks can't convert 2.2 pounds per kilogram. The recommended dose to get to the second level, let's do pounds, 2.9 pounds, milligrams per pound. So you weigh 200 pounds, that's 29 grams. Okay? If you are taking Robitussin D, it's 15 milligrams per teaspoon. So we're talking about very, very high doses. To get to the 4th level, where you're almost dead, which is really high, it's about 8 milligrams per pound. So we're talking about massive doses. You say, well, where do you get them? Well, they can buy a bunch of bottles of Robitussin D, drink all that syrup, get sick, or